Hi everyone, my name is Jay and I'm the host for Occupational Medicine Pearls podcast. Today I will be reviewing Pentachlorophenol, which is one of the chemicals that require workplace health monitoring. Let's start. From general description of PCP, we look at pure pentachlorophenol. It is a colorless or white needle-like crystal, so it may look like a whitish powder. Commercial grade PCP, on the other hand, can appear as a dark gray to brown solid with a phenolic pungent smell, so it will be hard to hide if it is there. It was once used as a preservative agent against timber-destroying fungus, substitute molds, and some timber-boring insects and termites. There are currently no approved agricultural or veterinary use in Australia. However, it may still be used in chemical manufacturing, and exposure may occur in sawmills, wood treatment facilities, construction sites, or where the lumber is used, recycled or installed. Example work activities may include handling or processing of wood that has been preserved with PCP and working near preserved wood processes. It may present in the air as vapor, aerosol, or particulate matter. It is absorbed through our skin, and it can, when someone come in contact with surfaces that has PCP on it, and there may be exposure to it. From non-occupational perspective, it can still happen with small amount of PCP absorption. It is found in all environmental media as a result of using widespreadly in the past. To have health monitoring for PCP, we will start with getting history of any current symptom for allergies, respiratory symptoms, and any skin allergies. On the physical examination, again, we look at any signs of atopy or eczema as skin problems, any signs of irritation. From the urine sample, we need to collect urinary total PCP and urine dipstick for hematuria and proteinuria assessment. We need to understand the metabolism of PCP to conduct health surveillance. When we expose to PCP, it is absorbed through intact skin or through the lungs and the gastrointestinal tract. The inhalation is regarded as 70 to 90% of the total absorption. Dermal absorption through the skin to the vapor can also be significant as well. However, only a relatively small amount of PCP is metabolized, and up to 78% of the absorbed dose is excreted intact in the urine. Only a small number of them are excreted as glucuronide conjugates. So the total urinary PCP levels may reflect the overall exposure of your body. In terms of the level, we are looking at 0.25 millimole per mole creatinine level. The limitation of urinary total PCP is that it is used for biological monitoring, not for biological effect, as it has poor correlation. There is also considerable variation between people on the level of PCP and how much they can conjugate that as a metabolism. As PCP is highly protein bound in blood, the metabolism half-life is very long. Approximately, it can take up to 20 days. The urine dipstick for hematuria and proteinuria should be carried out every 180 days, and that can be compared to the baseline result. The other method we can use is that plasma PCP level, which is regarded as 1 mg per liter in serum or plasma. Again, blood level has similar limitation to urinary total PCP that it is biological monitoring. For the workplace exposure standard, we set at 0.5 mg per cubic meter. And for the fitness for duty assessment, if a worker shows that clinical symptoms and the urinary or blood level of PCP higher than the biological monitoring safety mark, they should be removed from work. They can return to work when they are resolved all symptoms and any workplace control issues are resolved as well. Why they are not working, spot urine tests for total PCP should be repeated every 30 days until they fall below 0.25 millimole per mole creatinine. After this, we need to look at health effects of the PCP. PCP decouples oxidative phosphorylation in our body. As a result, part of the energy produced is lost as heat, so the body will heat up, which in turn will increase our metabolism indirectly. Effects of that can be seen in many parts of our body, particularly in the major organs that are sensitive to metabolism. So starting with your heart, it can cause tachycardia, chest pain. With the respiration, there will be increased respiratory rate and feeling distress, and skin will be dry and irritation, and the corneal opacity. With the liver exposure, it will cause hepatocellular damage, nausea, and vomiting. At the very high dose exposure, an individual may experience death from the overwhelming or increased metabolism in the nervous system. So there may be convulsions, loss of consciousness, and the heart will fail, and there could be respiratory paralysis and pulmonary edema. It will be similar to thyrotoxicosis when there is metabolic increase process happening, and the risk of these serious consequences is greater in the hot weather, in particularly if they have underlying kidney or liver impairment. From chronic exposure, the PCP can cause irritation and inflammation of upper respiratory tract and can cause bronchitis. They can irritate our eyes, nose, and skin. As a result, there will be increased prevalence of conjunctivitis, chronic sinusitis, dermatitis. Once it is in the body, it is broken down in liver and kidneys. We need to think about increased or deranged liver function and renal function as well. From the hematological, it can cause aplastic anemia. There are medications that can cause dehydration or that has anticholinergic properties, and diuretics, phenothiazine, antihistamine, and antidepressant. These medications can increase the susceptibility of people to expose with hypothermia. Aspirin can also have similar effect if we have taken together at the same time with high dose exposure or PCP. Finally, medications such as phenytoin, warfarin, furosemide, ethacrylic acid, naproxen, and ibuprofen can increase the level of free PCP chemicals in our blood, increasing the risk of potential toxicity. PCP itself is regarded as category 2 carcinogen, as someone having suspicious for having cancer, but there is no direct proven evidence of causing cancer. That's all for today's episode of Occupational Medicine Pearl. If you found useful for this episode of PCP, please share it with your colleagues, and that will be really appreciated. I'm Yi, and I'll see you next time.